Good afternoon, this is Aubrey and Jordan with Education, and today we're going to talk to you a little bit about Foley removals, what the protocol looks like for the nurse-driven Foley protocol removal, how to interpret it, what to do if your patient is showing signs of retention, and what the good justifiable reasons are for maintaining your indwelling catheter. So we have a written protocol on our urinary catheter placement, both the care, maintenance, and the removal. It's a very long policy, so I wanted to just point out a couple of things that you should focus in on when you're maintaining the care of this device for your patients. So one of the things that we've had brought to our attention is sometimes there are orders for a patient to have a Foley placed when they come in through the ED. One thing we wanted to point out is that the emergency room is not an ideal place to have a Foley placed because there's not private rooms for everybody all the time. There's a higher risk of contamination, and so in the protocol it actually states that they should delay putting the Foley in there unless they have to put it in because of a specific criteria that is pressing and that they have to have it placed immediately. And so our goal is to not have Foleys put in the emergency room if we can avoid it. If we have patients who come in that have a catheter present on admission, whether it's a chronic catheter or a catheter that was placed maybe in a different location and the patient came to us, we want to assess why they have that catheter in place. So did they need to continue having the catheter? If not, let's go ahead and get it out. If they need to maintain that catheter, so if it's like a chronic Foley catheter or if it's post-surgical for urology, we need to make sure that we get an order from our physician to maintain that catheter and have it documented in Epic. If the patient has a chronic catheter in place, then we need to get an order to change out that catheter. And then once the catheter is changed, we also need to send a sample to the lab so that we can get a lab run to make sure that there's not any kind of bacteria or growth in their urine. That way, if they come in with a UTI, we can go ahead and get them on treatment, and that we also don't get labeled with a CAUTI for a Foley that came into our facility from outside. For catheter removal, so we have to have a valid reason for having a catheter maintained within the patient. We need to be able to speak to that every shift, every day, anytime we go to rounds. We need to be able to speak while we have all of our lines in. And so you'll be able to see here, we're looking at the playground for Epic, but when the order is placed in for a urinary catheter, the physician actually has to put in here why the catheter is being placed, whether it's for acute retention, neurogenic bladder, post-op, if there's an open wound. There's a whole different order set for if the patient is having a urinary catheter inserted by a urologist. So they have to be able to validate why the catheter is being put in. Another part of the order set that automatically populates is this discontinuation piece. So the discontinuation of the urinary catheter 48 hours after insertion, unless indicated by the criteria that are set forth in the urinary catheter protocol. So when you go into our urinary catheter protocol, it's going to tell you very clearly what the reasons are for maintaining that catheter. So that patient, just because they need to have eyes and nose documented doesn't mean that they need to have an indwelling catheter. There's other ways that we can obtain eyes and nose. However, if they're having to have hourly eyes and nose, if they're getting large volumes of diuretics, if they are post-op within the first 48 hours, if they have an epidural catheter, if they have the catheter placed for comfort care, end of life, if they're critically ill. So those are reasons that we would need to maintain that indwelling catheter, but we need to make sure that we can speak to that every shift. So we do want to make sure that we have documentation of why we need to maintain that catheter and that our documentation supports that we're not just continuing what was entered by the previous shift, but that we're actually investigating those reasons. So once your patient no longer qualifies to have the indwelling catheter in place, then we need to look at getting it out and make sure that we're doing that as quickly as possible. When we look at our protocol for urinary catheter removal, it tells us on here what the protocol is for looking to remove it. If the order for strict eyes and nose is no longer valid, or if the patient is able to cooperate with monitoring of their eyes and nose without having the catheter in place, then we need to go ahead and pull it out. And that's what it tells us right here. If they don't meet the criteria, then we need to go ahead and get it out. If they meet the criteria for having it, then we obtain an order continuing the catheterization. Once we take the catheter out, we need to follow this decision tree that helps us figure out how to get it out the best way possible for the patient while maintaining the safety of the patient and looking for issues, for distended bladder, and other signs of urinary retention. And so you're going to void hopefully within 6 hours of removal of the catheter. If not, then this walks you through exactly what you need to do. You're going to go in and scan the bladder on the patient. You're going to look to see how much volume is out, and then based on that, it'll tell you what you need to do. Do you need to do intermittent catheterization, or do you need to extend your monitoring time for an additional 2 hours? If they put out greater than 300 mils in 6 hours, then you can scan the bladder. If they have less than 100 left in their residual, then you can stop at that point. They don't need any further monitoring. But if they have more than 100 mils still left in the bladder, then you're going to check them again in 6 hours, and you're going to continue that trend for 24 hours to make sure that they are not having any retention signs or symptoms. If they're able to spontaneously void, but it's less than 300 mils in 6 hours, then we're looking at possible retention issues. And so we're going to scan the bladder. Then based on what the output is and what the residual volume is, it walks you through, do you rescan them in 2 hours? Do you stop because you don't need further intervention? And so this all walks you through exactly what you need to do. It gives you guidelines and values. Also, when you're looking for your patient to void, make sure that we're trying to create an environment that's going to be conducive for them to be successful. So a lot of times retention has to do with the muscles not being active for a long time. They have to sort of kick back in and get used to squeezing. Some of it can be positional. So if your patient is used to standing up to void, so especially with male patients, and it's safe to let them do so, let them stand up to void so that they can get back into that habit and sort of kick those muscles back in. If you have any questions, please feel free to comment below or reach out to the education department. Thank you so much.